Today we have the second session on diabetes mellitus, and in this session we will be discussing about the anti-diabetic drugs other than insulin. So, what are the learning objectives of today's session? Today I'll be talking briefly about diabetes mellitus and about the anti-diabetic drugs, their relevant pharmacology, their uses, adverse effects, and contraindications. So, diabetes mellitus is a metabolic disorder which is characterized by elevated plasma glucose, and this is due to impaired glucose homeostasis. So normally the glucose requirement of our body is obtained from the glucose that we consume, but in fasting state it is met by fatty acid oxidation. But this does not work with the brain because brain requires glucose, and glucose is the only food for the brain, and this glucose is provided by liver. And this is by breaking down glycogen and also synthesizing glucose from amino acids and fatty acids. So that is glycogenolysis and gluconeogenesis. So the glucose homeostasis occurs with the help of the pancreas. Pancreas has got an endocrine area, and this is called as islets of Langerhans. And from the islets of Langerhans, there are different types of cells in the islets of Langerhans. And the beta cells of the islets of the Langerhans, it produce a hormone known as insulin. And this insulin secretion, insulin helps in glucose homeostasis. And the secretion of insulin is stimulated by glucose, amino acids, fatty acids, and also ketone bodies. So the primary stimulus for insulin secretion is food. So when you're consuming food, it will stimulate the central nervous system to release norepinephrine and also to release acetylcholine, which will stimulate insulin secretion. But the most important stimulus for insulin secretion is the glucose that is present in the food. And the second most important stimulus for insulin secretion are the hormones that are released from the gastrointestinal tract. So these hormones, they are called as incretins, and these include glucagon-like peptide 1 and gastric inhibitory polypeptide. So these are released from the GIT, and these hormones will also stimulate insulin. So after synthesis of insulin, insulin is stored in secretory granules of the beta cells. And normally in the beta cells, there is movement of potassium from the intracellular to the extracellular through potassium channels. And these channels remain open in the resting state. So because potassium is being lost, the intracellular polarity will become negative. So this cell will be in a hyperpolarized state. So what happens when you are consuming glucose or consuming food? So the glucose from the diet will be transported into the beta cells of the pancreas with the help of glucose transporter 1. And inside the beta cells, it will get converted to ATP. And this ATP will inhibit these potassium channels. So this potassium buildup will occur inside the beta cells, and this will result in depolarization. So this depolarization will trigger the opening of calcium channels, and calcium will enter into the cell. And this calcium will catalyze the fusion of this this secretory granules, and that will secretory granules with the cell membrane, and that will result in release of insulin. And the incretin hormones that are released from the gastrointestinal tract when you're consuming food, that is GLP-1 and GIP. Both these agents, they have receptors in the beta cells, and binding of this GLP-1 and GIP will increase the levels of cyclic AMP intracellularly in the beta cells. And the cyclic AMP will block these potassium channels, and blocking these potassium channels will result in depolarization, and that will result in release of insulin. So what does insulin do? Insulin is a hormone that helps us utilize the glucose from our diet. So normally inside cells, there are transporters, glucose transporters called as GLUT4. And these are present in the cytoplasm in resting state. So when insulin binds to its receptors which are present in the cell, this GLUT4 transporters, that is glucose transporter 4, will be translocated into the cell membrane. And this will result in movement of glucose from the extracellular into the intracellular. So that will help the cells take up glucose. And this happens predominantly in the adipose tissue and also in the skeletal muscles. So when this happens, adipose tissue and skeletal muscles will be able to take up more amount of glucose. And it also stimulates the anabolic processes in the adipose tissue and also in the skeletal muscles. Insulin also acts on the liver, and in the liver, it helps in the storage of glucose. And this glucose is stored as glycogen by a process called as glycogenesis. Normally, insulin is secreted in small amounts, even at rest when you're not having food. So this is called as basal insulin secretion. And after you consume food, insulin is released in two phases, phase 1 and phase 2. Phase 1 is due to glucose that is present in the diet, and phase 2 of insulin secretion is due to incretins that are released from the gastrointestinal tract. So diabetes mellitus is a condition in which there is reduced secretion of insulin or reduced action of insulin. Insulin is released in normal amounts, but insulin is not acting, or a combination of both. So when insulin is reduced or insulin is not acting, this will result in increase in plasma glucose. And diabetes mellitus is very important because India and China have the largest population of diabetics in the world. And these anti-diabetic drugs, they are predominantly used for the treatment of type 2 diabetes mellitus. So we'll be discussing about type 2 diabetes mellitus. Type 1 diabetes mellitus has been discussed in the previous session. So in type 2 diabetes mellitus, insulin is released in normal amounts or in lower amounts, but the tissues, they are not responding to insulin. They are resistant to insulin. So this is known as insulin resistance. So the anti-diabetic drugs, they are classified depending upon their mechanism of action. So there are agents that increase insulin secretion and reduce the plasma glucose. There are agents that reduce insulin resistance. There are agents that reduce glucose reabsorption from the kidneys. And also there are agents that reduce gastrointestinal absorption of glucose. We'll see each one in detail. So the agents that increase insulin secretion, they include many agents. These include sulfonylurea, meglitinide analogs, GLP-1 agonists, and dipeptidyl peptidase 4 inhibitors. So we'll see for sulfonylureas first. There are three sulfonylureas are used for the treatment of type 2 diabetes mellitus. These include glipizide, glimepiride, and glyburide. Glyburide is also known as glibenclamide. So I have mentioned that this beta cells of the pancreas, they have got potassium channels through which the potassium moves from the intracellular to the extracellular. And this happens in the resting state, and that will result in hyperpolarization of these beta cells, which will prevent the insulin from getting released. So when you are administering sulfonylureas will bind to these potassium channels and prevent the outward movement of potassium. So this will result in potassium accumulation intracellularly, which will result in depolarization, and that will result in release of insulin. And the peculiar thing about sulfonylurea is that insulin secretion with sulfonylurea is stimulated even when the plasma glucose is low. So even when the person is having low plasma glucose, there will be increased insulin secretion that will further decrease the plasma glucose. So the chances of hypoglycemia are very high with sulfonylureas. And sulfonylureas on long-term use, it will also increase the sensitivity of peripheral tissues to insulin. And sulfonylureas also reduce the hepatic degradation of insulin. So all these sulfonylureas, they are available as oral formulations. And important property of sulfonylurea is that it gets bound to plasma protein. So this bound form of bound drugs, they do not produce any action. So though these sulfonylureas, they've got very short half-life. Since they are bound to albumin, they have got a longer duration of action because they are slowly released into the circulation. So these agents, they are used once daily. Most of the time it is used once daily. Sometimes it need to be used twice daily. And sulfonylureas, they are metabolized by the liver, all the sulfonylureas. So if you are using sulfonylureas, you have to be very careful about the liver function of the patient, because in hepatic failure, the metabolism of sulfonylureas will be reduced. That will result in prolonged action and hypoglycemia. And these metabolites, they are eliminated by the kidneys. And these metabolites, some of the metabolites, they also have got plasma glucose lowering effect. So if the patient is having renal failure, these metabolites can accumulate and that can also produce hypoglycemia. So sulfonylureas need to be used very cautiously in patients with hepatic and renal failure. So sulfonylurea, they are used in type 2 diabetes mellitus and they produce a reduction in HbA1c by 1 to 2%. Not all the patients who receive sulfonylurea have a response to sulfonylurea. Only 50 to 80% of the patients who are receiving sulfonylureas respond well to these agents. And over a period of time, the response to sulfonylurea reduces because sulfonylurea acts by increasing the insulin secretion. But as time passes, the diabetes mellitus worsens. That means that the beta cells, they undergo progressive destruction, and as the diabetes progresses. So when the beta cells are gone, sulfonylureas will be able to stimulate less amount of insulin secretion. So that is called as the resistance to sulfonylureas. So since sulfonylureas, they increase the insulin secretion, and insulin is an anabolic hormone, it will result in weight gain. And weight gain is very commonly seen with sulfonylurea. Next important adverse drug reaction of sulfonylurea is hypoglycemia, because sulfonylureas, they stimulate insulin secretion even when the plasma glucose is very low. So it can produce serious hypoglycemia. Sulfonylureas can also produce cholestatic jaundice, and sulfonylureas, it has got some allergic response, and this allergic response is predominantly seen in the hematopoietic cells, and that can result in adverse drug reactions like agranulocytosis, aplastic anemia, and hemolytic anemia. And sulfonylureas, I have mentioned that they have got very high plasma protein binding, and the unbound drug is the one that produces effect. So it has got very high potential of interaction. So if you're giving drugs that has got high plasma protein binding, it can displace sulfonylurea from the plasma protein binding site and can lead to hypoglycemia. These include salicylates if you are administering sulfonylurea with salicylates, if you are administering it with sulfonamides, clofibrate, all these agents can potentiate the a hypoglycemic effect of sulfonylurea. And also sulfonylurea, they are metabolized by liver and they are excreted by the kidneys. So some of the agents, they can induce the hepatic microsomal enzymes that will increase the metabolism of sulfonylurea. For example, rifampicin. Rifampicin is an enzyme inducer and it will increase the metabolism of sulfonylurea. And some drugs, they will inhibit the hepatic microsomal enzyme. So these agents will prolong the duration of action of sulfonylureas. So these include azole antifungals. So there is another group of agent which acts by similar mechanism. They have got similar uses and adverse drug reactions. So these are known as meglitinide analogs. There are two agents, two meglitinide analogs that are available, repaglinide and naticlinide. And these agents, they are similar to sulfonylurea in almost every aspect. So the next group of agents that increase insulin secretion, these are GLP-1 agonists. So these are the drugs in which maximum research is going on right now. So we have 5 GLP-1 agonists currently available in the market. These include exenatide, liraglutide, dulaglutide, lixisenatide, and semaglutide. So food in our gastrointestinal tract will stimulate the release of incretin hormones, that is GLP-1 and GIP. They bind to the beta cells of the pancreas. They increase the cyclic AMP intracellularly, which will block the potassium channels, which will result in depolarization and release of insulin. GLP-1 also has got action in the brain, and stimulation of these receptors will reduce the appetite. So this GLP-1 agonist, by reducing the appetite, it produces significant weight loss. And they also reduce the glucagon and also they reduce gastric empty. So basically GLP-1 agonists, they increase the insulin secretion and also they reduce the appetite. And this insulin secretion, unlike sulfonylurea, it is only stimulated in presence of glucose. So these GLP-1 agonists, they do not produce hypoglycemia. But the problem with this GLP-1 agonist is that these agents, they are available as injections, subcutaneous injection. So among these agents, exenatide is the shortest acting GLP-1 agonist. It has to be given 2 times daily. Liraglutide is even longer acting. It can be given once daily. And the most popular one is semaglutide. Semaglutide and dulaglutide. Both these agents, they have got extremely long half-life. So uh, it needs administration once a week. Semaglutide is also available as oral formulation, and if semaglutide is used orally, it has to be given once daily. GLP-1 agonists, they do not have any recommendation. Most of the GLP-1 agonists, they do not have any recommendation in hepatic and renal failure. But exenatide and lixisenatide, both of them are eliminated primarily by the kidneys. So in renal failure, these two agents has to be used cautiously. And currently, GLP-1 agonists, they are used for the treatment of type 2 diabetes mellitus. They reduce the glycated hemoglobin by 0.8 to 1.5%. GLP-1 agonists, they are also approved for the treatment of obesity. And currently, the GLP-1 agonist, which has got maximum weight loss, is semaglutide. You need not have the person need not be diabetic to use it for obesity. It can be used in diabetic obese patients and also in non-diabetic obese patients. And GLP-1 agonist, it has also been approved for prevention of cardiovascular events in patients who are at high risk. So these are the 3 indications of GLP-1 agonists. And the major adverse drug reaction is nausea and vomiting. Most of the patients, they complain about nausea and vomiting. And this is due to stimulation of the central nervous system. But this usually reduces over a period of time. And GLP-1 agonists, they are also associated with gallbladder disease, especially liraglutide and also semaglutide. GLP-1 agonists, they also increase the risk of pancreatitis. The major problem with GLP-1 agonists is that they are very expensive and people do not like to take injections very frequently. But the newer ones, they are used once weekly, but still they are very expensive. And very recently in 2025, another agent has been approved, which is GLP-1 agonist, but it has got additional GIP agonistic action. So this is a dual agonist. It is terzepatide, GLP-1 and GIP-1 agonist. So it is used for the treatment of type 2 diabetes mellitus right now, and it reduces the glycated hemoglobin by 2 to 2.3%. And it is also approved for the treatment of obesity. It reduces the weight by 10 kilogram if used over a period of 1 year. Terzepatide is also available as a subcutaneous injection, and it is used once weekly. So the next group of agents that increase the insulin secretion are DPP-4 inhibitors. So these include many agents: allogliptin, linagliptin, sitagliptin, vildagliptin, saxagliptin, and teneligliptin. So the incretins, they are metabolized by this enzyme DPP-4, that is dipeptidine peptidase 4. So the incretins are GLP-1 and GIP, and they are metabolized by this enzyme. So if you are inhibiting this enzyme, this will result in increased levels of incretins. And the incretins obviously stimulate release of insulin. So that will result in reduction in plasma glucose. So DPP-4 inhibitors, saxagliptin is the DPP-4 inhibitor that is metabolized by the liver. And saxagliptin requires dose reduction in liver failures. Others are eliminated unchanged in urine. And linagliptin is somewhat eliminated by the hepatobiliary system. So they are used for the treatment of type 2 diabetes mellitus, and they've got very mild reduction of glycated hemoglobin, 0.4 to 0.8%. And the major adverse drug reaction is joint pain. So when you are comparing this DPP-4 inhibitors to GLP-1 agonists, DPP-4 inhibitors increase the incretin levels to physiological levels, but GLP-1 agonists, they produce action similar to pharmacological levels of incretin. So they are far superior to DPP-4 inhibitors. So the second group of agents, they are the agents that reduce insulin resistance. So these include 2 agents, metformin and pioglitazone. Metformin is the first line agent for the treatment of diabetes mellitus. So metformin, it acts by activating an enzyme called as AMP kinase. And usually in liver produces glucose from fats and amino acid, and this is known as gluconeogenesis. And this AMP kinase enzyme will inhibit this gluconeogenesis, thereby reducing the glucose production from the liver. So if somebody is asking you what is the mechanism of action of metformin, you should say that it inhibits hepatic gluconeogenesis. So metformin is available in variable doses. It can be used from 500 milligram per day to 2000 milligram per day, and an oral formulation. It has got decent bioavailability, 70 to 80% bioavailability, and metformin is eliminated primarily by the kidney. So it should be used very cautiously in patients who are having end-stage renal disease. It should be ideally avoided. And metformin is currently the first line agent for the treatment of diabetes mellitus, type 2 diabetes mellitus, and it reduces the glycated hemoglobin by 1 to 2%. Metformin is very cheap, and the chances of hypoglycemia are very low because it does not increase insulin secretion. It will just inhibit hepatic gluconeogenesis. And metformin also prevents the microvascular complications of diabetes mellitus. And other than type 2 diabetes mellitus, metformin has got another off-label indication. It is used for polycystic ovarian syndrome, and it normalizes ovulation in patients who are having polycystic ovarian syndrome. So the major adverse effect of metformin include gastrointestinal adverse effects. It includes nausea and vomiting, bloating, and diarrhea, or a combination of any of these. And using metformin will reduce the plasma B12 levels by 20 to 30%. So it is recommended to supplement B12. Metformin also increases the risk of lactic acidosis. It causes accumulation of lactic acid, and this is very particular in patients who are having stroke, myocardial infarction, or heart failure. So the second agent that reduces insulin resistance is pioglitazone. So normally, adipose tissue and skeletal muscle and liver contains a receptor known as PPAR gamma. This is peroxisome proliferated activated receptor, and activation of these receptors or stimulation of these receptors will enhance the action of insulin in these tissues. So what insulin does in these tissues is the movement of plasma glucose into these tissues. So when these receptors are stimulated, this will result in movement of glucose into the adipose tissue, into the skeletal muscle, and also into the liver. And it also inhibits hepatic gluconeogenesis. So pioglitazone acts by acting on PPAR gamma receptors. But there is another isoform of PPAR receptor, which is called as PPAR alpha, which is predominantly present in the adipose tissue. So it is not completely selective for PPAR gamma. Due to the action on PPAR alpha, it causes changes in the plasma lipids. So it is an agent that can increase the levels of high density lipoprotein, and also it increases the levels of plasma triglycerides. Pioglitazone is available as an oral formulation, and pioglitazone is metabolized predominantly by the liver. So if you are using pioglitazone along with enzyme inducers, agents that increase the metabolism, it can reduce the action of pioglitazone. Similarly, if you are using pioglitazone with agents that inhibit microsomal enzyme, it can prolong the action of pioglitazone. So it produces a it is used for type 2 diabetes mellitus, and it produces a glycated hemoglobin reduction of 0.5 to 1.4%. And the major adverse drug reaction of pioglitazone is weight gain. 2 to 4 kilogram weight gain is usually common with pioglitazone. And this is due to anabolic effects, adipose tissue synthesis, and also due to fluid retention. And this fluid retention is particularly very problematic in patients who are having heart failure, because fluid retention can worsen the heart failure. Pioglitazone also produces bone fractures, and this is very particularly common in elderly females. So The next group of agents, so we have covered about agents that increase insulin secretion. We have covered the agents that reduce insulin resistance. And the third group of agents are the agents that reduce glucose reabsorption. So the plasma that is filtered by the nephron uh, is called as the ultrafiltrate, and the ultrafiltrate usually contains glucose. And this glucose is reabsorbed in the proximal convoluted tubule with the help of a transporter called as SGLT2, that is sodium glucose co-transporter. And this will transport glucose from the ultrafiltrate into the cell, and then it will pump it into the interstitium. So this transporter is inhibited by these agents. So these agents, they are called as SGLT2 inhibitor, sodium glucose co-transporter 2 inhibitor. So because this is not reabsorbed, it will result in glucose is not reabsorbed. It will result in excretion of glucose through the kidney. So there are 4 agents that are available right now: canagliflozin, empagliflozin, dapagliflozin, and ertugliflozin. So these agents will increase the excretion of sodium and glucose through the urine. And these agents, they are available as oral formulation. Once daily is the commonly used frequency. And all these agents, they are metabolized by glucuronide conjugation in the liver. SGLT2 inhibitors, they are used for the treatment of diabetes mellitus, type 2 diabetes mellitus, and it produces a HbA1c reduction of 0.7 to 1%. SGLT2 inhibitors are also approved for the treatment of heart failure. They can also be used as a diuretic agent. And SGLT2 inhibitors, they are especially canagliflozin, dapagliflozin, and empagliflozin. They are used for reduction of the progression of renal disease. Since they increase the excretion of glucose in urine, they rarely produce hypoglycemia. And because glucose is an osmotically active substance, it will draw fluid along with glucose. This will result in fluid loss, and it can produce a modest weight loss of 2 to 4 kilograms. So since we are losing a lot of glucose in urine, it can result in a mild increase in urinary tract infection, 2% increase in urinary tract infection, and also genital tract infection, which is 3 to 5%. And SGLT2 inhibitors has an important adverse type reaction. It increases the risk of diabetic ketoacidosis. Among the anti-diabetic agents, the agent that increases the risk of diabetic ketoacidosis are SGLT2 inhibitors. So the last group of agents, they are alpha glucosidase inhibitors. That these agents will reduce the gastrointestinal absorption of glucose. So the complex carbohydrates, they are broken down into simple carbohydrates by the help of an enzyme called as alpha glucosidase, which is present in the brush bordered epithelium of the intestinal cells. And these complex carbohydrates include starch, dextrin, disaccharides, etc. And these will be absorbed by the intestine. So inhibiting this enzyme will reduce the gastrointestinal absorption of glucose. And these agents also increase the levels of GLP-1, thereby increasing insulin secretion. So 3 alpha glucosidase inhibitors are currently available in the market. These include acarbose, neglitol, and voglibose. And these agents, they are used for the treatment of postprandial hyperglycemia, and they produce a glycated hemoglobin reduction of 0.5 to 0.8%. And since this starch and complex carbohydrates are excreted, they produce gastrointestinal adverse reaction. The most important ones are flatulence and also blocking. So these are the major agents that are used for the treatment of type 2 diabetes mellitus. And there is a management algorithm for type 2 diabetes mellitus. So in a patient who is having type 2 diabetes mellitus, we assess the glycated hemoglobin, and we will start them on metformin. Metformin is the current first line agent, unless it is contraindicated, like end-stage renal disease. And we also screen for microvascular and macrovascular complications of diabetes mellitus. And if the person is having comorbidities like dyslipidemia, hypertension, obesity, and cardiovascular disease, we'll treat that as well. And after 3 months, we will reassess the glycated hemoglobin. And if it is not getting under control, we will use a second agent along with metformin. We can choose any of the second line agents which can be used. And after a period of time, we will reassess the HbA1c. And if the HbA1c is not coming under control, you can add another agent or you can add insulin to metformin. So this is the main management algorithm. So I have some MCQs for you based on today's session. These are previous year's questions for INI-CET. So you can answer in the chat box. Anti-diabetic agent that causes bone fracture in females. A. Liraglutide. B. Canagliflozin. C. Pioglitazone. And 4. D. Voglibus. Yes, pioglitazone. Pioglitazone produces bone fractures, especially in females. Second question, a diabetic patient started complaining of itching around the vulvovaginal area after starting an anti-diabetic drug. Which would be the probable agent that caused this adverse drug reaction? A. Acarbose. B. Linagliptin. C. Canagliflozin. And D. Liraglutide. Yes, canagliflozin. Canagliflozin is an SGLT2 inhibitor. It inhibits the reabsorption of glucose from the proximal convoluted tubule. So that will result in increased excretion of glucose, which will result in increased risk of urinary tract infection and also genital infection. Third question, identify the anti-diabetic drug that decreases HbA1c by causing an increase in GIP and GLP-1 levels and decrease glucagon. That oral drug causes reduction in both pre and postprandial glucose. So the options are A. Liraglutide, B. Allogliptin, C. Pramlintide, and D. Metformin. So most of the agents that we have talked about as GLP-1 agonists. So these agents, they are agonists at GLP-1 receptors. That doesn't mean that they act on GIP. Right. So they do not increase the levels of GIP. And liraglutide is a GLP-1 agonist, but it is not available orally. Look at the third sentence, that oral drug causes reduction in both pre and postprandial glucose. So this should be an agent that will reduce the breakdown of GLP-1 and GIP. So that is obviously allogliptin. Which of the following DPP-4 inhibitor is given in CKD patient without dose modification, which can be used in chronic kidney disease? Yes, linagliptin. Linagliptin is cleared by the saxagliptin. Saxagliptin is predominantly metabolized by the microsomal enzymes. Others are eliminated by the kidney. So it can be used safely in patients who are having CKD. An anti-diabetic drug is recently approved for the treatment of heart failure with low ejection fraction along with low urine output. Identify the drug from the options. Linagliptin, rosiglitazone, empagliflozin, insulin degludec. Anybody? Anti-diabetic drug recently approved for the treatment of heart failure with low ejection fraction. So these are the questions that were asked in the previous years of INI-CET. I hope this was useful.